Epilepsy and Seizures, brought to you by Macomb-Oakland Regional Center Training Department. As a caregiver, you have a unique and critical role in helping to facilitate the overall health, safety, and well-being of a very vulnerable population. You are a vital resource and bridge to health and wellness for the people you are providing care for. In this training, it is our hope and privilege to provide you with the most current and accurate healthcare knowledge to assist you in improving and celebrating the lives you support. Epilepsy. Let's talk about it. What is epilepsy? Epilepsy is a disorder of the central nervous system in which the result is irregular electrical activity in the brain causing seizures. The seizure includes episodes of unusual sensations and periods of behavior and loss of awareness in some cases. A seizure is a burst of uncontrolled electrical activity in the brain between brain cells, also known as neurons. Epilepsy is diagnosed when an individual experiences 2 or more unprovoked seizures separated by at least 24 hours, or after one seizure with a high risk for more. Epilepsy is a medical condition, like any other disorder, such as asthma or diabetes. Around the world, the number of individuals with epilepsy is approximately 65 million. 3.4 million individuals have epilepsy in the United States, with approximately 150 new diagnoses per year. Unfortunately, 1/3 of individuals diagnosed with epilepsy have seizures that are unable to be treated with medications as they do not work for them. Individuals with epilepsy can just experience seizures, or they can be other neurological or developmental diagnoses as well. What causes epilepsy? It is natural that when someone is diagnosed with a disorder to ask why. What caused it, or how did it happen? With epilepsy, unfortunately, about half of the individuals that are diagnosed, there is no known cause. However, when the cause is unknown, treatment determination and success is far more achievable. Known causes of epilepsy are categorized in 5 groups: genetic, immune-related, infection, metabolic, and structural. Epilepsy in individuals with intellectual and developmental disabilities. In looking at epilepsy in the individuals we serve, information is difficult to come by. However, this is what we do know, referenced by the Epilepsy Foundation. Epilepsy is considered to be a developmental disability when it begins and is diagnosed before the age of 18. Epilepsy can occur in children who have not been diagnosed with developmental disabilities. However, epilepsy is common in children who have developmental intellectual disability. Nearly 30% of children with an epilepsy diagnosis have other developmental disabilities. In one study, children with intellectual developmental disabilities, or what we refer to as IDD, and a diagnosis of cerebral palsy had a 35% chance of developing epilepsy. Children with IDD alone had an 8% chance of developing epilepsy, while children that experienced a brain injury after birth had a 75% chance. The risk of a child with a developmental disability experiencing an unprovoked seizure by age 5, generally speaking, is about 4 times greater than an average population. How is epilepsy diagnosed? Diagnosing epilepsy can be complex and sometimes difficult. With someone experiencing a seizure for the first time, a clear description of the event and what the seizure looked like is an important component from a baseline perspective. Information such as what was happening before the seizure, length of the seizure, body movement, individual's ability to respond after the seizure are just a few of the questions that will be asked, but also information that will give the healthcare team an idea as to whether it was a seizure or what type of seizure it was. As a direct support professional, observing, reporting, and documenting in a seizure report the event is paramount in helping the healthcare provider determine the proper diagnosis and treatment plan. Diagnostic tools would include a complete medical history, physical and neurological examination, appropriate blood work, and any other tests. These informational pieces can help with diagnosis of epilepsy along with finding any other conditions or causes that can be a contributing factor. An EEG, or what we refer to as an electroencephalogram, is one of the most important tests in the diagnosis. This will record the brain's electrical activity. These patterns of activity are unique in particular seizure types that will assist in a diagnosis and treatment. One must remember that a standard EEG is a snapshot of what an individual's brain activity looks like at the moment and may not capture seizure activity at the time of testing. However, there are several types of EEGs that can be ordered by the healthcare provider depending on the individual's needs. Magnetic resonance imaging, or an MRI, scan uses strong magnets and radio waves to create a detailed view of the brain. This may be able to detect lesions or abnormalities in the brain that could be associated with seizure activity. Computerized tomography. A CT scan uses X-ray to obtain cross-sectional images of the brain. CT scans can reveal abnormalities in your brain that could cause a seizure, such as tumors, cysts, or bleeding. A PET scan uses a small amount of low-dose radioactive material that injected into a vein to help visualize active areas of the brain and detect abnormalities. Seizure triggers. With some individuals, a seizure may occur in particular situations or patterns. It is something that occurs very frequently before the seizure begins. This is what is referred to as a seizure trigger. For example, the seizure may occur when waking up or only during sleep, at the beginning of a menstrual cycle, or when there is a flash of light. As a direct support professional, this is information that, when recognized and documented, not only helps with diagnosis, but also can be significant when preparing for the seizure that is about to happen. When an individual experiences that seizure trigger, one can quickly create a safe environment for the individual to prevent injury during the seizure that is about to follow. Also, by knowing what the seizure trigger is, situations can be avoided that could put the individual in harm's way. For example, if an individual's seizure trigger is flashing lights, going to see fireworks on a July 4th holiday would not be something this individual could participate in without consequences. Common seizure triggers. Common seizure triggers are missed medications. This is the #1 cause of seizure triggers. Stress, illness, flashing lights or photosensitivity, sleep deprivation. They can be specific to time of day or night. Alcohol, including alcohol withdrawal. Drug use, cocaine, and other recreational drugs. Menstrual cycles. Poor diet, not eating well. and excessive caffeine. Seizures and auras. Some individuals that have seizures have what they experience as an aura. An aura in epilepsy is a feeling or sensations that happen just before the seizure begins. Some individuals refer to it as a warning. Not everyone with epilepsy experiences an aura before their seizure. However, if they do, it gives them the opportunity to prepare for what is about to happen. It may give them time to lay down somewhere to decrease injury or swipe their vagus nerve stimulator to interrupt or stop the seizure. An aura may include visual changes as bright lights, visual patterns, distortion, or objects. They may hear sounds or voices. They may smell something strange or taste something unusual. Numbness or tingling on the side of the face or body. A feeling of deja vu. Sudden anxiety or nausea or abdominal discomfort. Types of seizures. Seizures can be of many different forms. The following information is a general description of different types of seizures. An individual's diagnosis will be very specific to the personality of their seizure activity, and treatment will be addressed and implemented accordingly. No two individual seizures will look the same, so it is important to understand the individual's diagnosis. Generalized onset tonic-clonic seizures. What used to be known as grand mal. It's comprised of two stages, the tonic phase and a clonic phase. The tonic phase begins with this phase first. Individuals will experience muscle stiffening, loss of consciousness, may cry out from the force of air past the vocal cords. They may bite their tongue or cheek. The clonic phase, this is the second phase of the seizure. Individuals' arms and legs begin to jerk rapidly and rhythmically and will last a few minutes, and jerking will begin to slow down and stop. Individuals' skin may also appear dusky or blue. They may become incontinent of urine or stool as the body relaxes and may be confused and have difficulty orientating while coming out of the seizure. The postictal phase. The postictal phase of recovery is the period of time after the seizure has ended and the individual is recovering. Every individual's recovery is different and can last a few minutes or several hours. This is a time that the individual should be closely monitored and watched until they return to baseline. As a direct support professional, you must monitor closely. The postictal phase, or the recovery phase of the seizure, may include confusion. They may be sleepy, disoriented. They may have loss of memory. They may feel embarrassed and scared. They may be lightheaded and slow to respond. It can last a short period of time or hours. General onset absence, which was historically referred to as petit mal seizures. A simple absence seizure is noted as a vacant stare, which may be mistaken as daydreaming or not paying attention that lasts approximately 10 seconds or as long as 20 seconds. Signs and symptoms of absence seizures include sudden stop in motion without falling, lip smacking or chewing motion, hand rubbing, small movements of the hands, and eyelid flutters. Afterwards, there's no memory of the incident. Some individuals have multiple episodes a day, which can interfere with school, work, or daily activity. Focal onset impaired awareness, or what was commonly referred to as the complex partial seizure. Impaired awareness seizures refer to vocal seizures that start in one hemisphere of the brain and are associated with consciousness and being impaired. Historically known as complex partial seizures, they are now called focal impaired awareness seizures or focal onset impaired awareness seizure. What does it look like? Usually starts with a blank stare and a dazed facial expression. Individual is not aware of what is going on or will not remember after the event. Individual may perform repetitive random movements, be clumsy, may not be able to talk normally and mumble. Individuals may run and be aware of what can be unsafe. Typically lasts 1 to 2 minutes and may be followed by confusion. These seizures for the individual have the same pattern and actions tend to be predictable. What can you do to help during an impaired awareness seizure? Speak quietly, calmly, and in a reassuring manner as they may be able to hear you. Do not restrain them unless absolutely necessary to keep the person safe. They may be confused and react aggressively as they may be agitated. Simply guide them out of harm's way. They will take the path of least resistance. Keep the person safe from harm. Keep them away from areas and equipment that could hurt them. For example, the stove, barbecues, stairways, or an open pool. Beware of their surroundings. Could they exit the home building and wander to a road or busy street? Other behaviors during these focal seizures may cause worry or embarrassment, but are usually not dangerous. These include screaming, kicking, ripping up papers, disrobing, pick up objects that don't belong to them. Remain next to the individual, and if these situations occur, to prevent injury. If the individual is known to have unusual automatic movements, guide them in a quiet and reassuring manner to a more private place if possible. Vocal onset aware simple partial seizures. A vocal onset seizure begins in one side of the brain. Historically, they were called partial seizures. Vocal onset seizures are the most common types of seizure experienced by individuals with epilepsy. With this type of seizure, the individual has no loss of awareness of their surroundings during it. Jerking in one or more parts of the body or sensory or perceptual changes that may or may not be obvious to onlookers takes place during this type of seizure. However, the person is aware of what occurs during the seizure. Atomic seizures, or what has been referred to in the past as drop attacks. When describing tonic seizures, it is described in relation to muscle tone. Muscle tone is the muscle's normal tension. Atomic means without tone. When an atomic seizure, the individual's muscle suddenly becomes limp. These seizures are also called drop attacks or drop seizures. What does it look like? Part or all of the individual's body may become limp. If standing, the person often falls to the ground. The individual's head may nod or drop forward, and the person may drop things. These seizures typically last less than 15 seconds, and recovery is within minutes generally. The individual is a fall risk, therefore their risk of injury is high when they fall. A helmet or other protective gear may be needed to protect from head trauma. Treatment of seizures. Medication. In most epilepsy diagnoses, medications are used to treat epilepsy. They are called anti-seizure medications. There are approximately 30 plus anti-seizure medications that are currently approved to treat epilepsy. Seizure management with medications is tricky. About 60% of individuals have good seizure management with the first or second medicine that they try. However, a survey suggests that 50% of adults still have seizures. If an individual is not getting good seizure control in the first 2 to 3 medicines prescribed and tried, they should be seen by an epilepsy specialist. Other treatment options include surgery, dietary therapy, vagus nerve stimulation, or VNS, and responsive neurostimulation, RNS. Treatment is always specific to the individual's diagnosis. Need to know about seizure medications. Be aware of all the side effects of seizure medications and monitor closely. Can cause sedation, dizziness, and difficulty with coordination. Therefore, an individual is at risk for fall and injury. May see changes in appetite and weight loss. Monitor closely for changes in eating habits and contact the prescribing physician. Special considerations for seizure medications. Laboratory blood work to check medication level in the blood is a big part of safe medication management for seizure medications, as they can cause problems in the liver. Schedule those appointments as requested by the prescribing healthcare provider and follow the instructions given before testing to ensure accurate results. Remember, changes in medication dosing and good seizure management are dependent on accurate laboratory results. Following instructions before laboratory blood draw appointments is paramount. The vagus nerve stimulation. As mentioned earlier, there are a number of treatment options depending on an individual's diagnosis. As a direct support professional working with the developmental intellectual disability community, vagus nerve stimulation is often seen with the individuals you serve. It is a small device, known as a generator, that is implanted under the skin in the left side of the chest. A small thin wire electrode goes from the generator up the neck and attached to the vagus nerve. The device delivers pulses and stimulation at regular intervals. If the individual is aware a seizure is about to happen, they can swipe a magnet over the generator in the left chest area to send an extra burst of stimulation to the brain. This can either stop the seizure, minimize the seizure intensity, or shorten the seizure. The benefits of VNS appear to improve over time. It is noted that seizures decrease by 50% or more in about 45% of people who have this device implanted. Quality of life. The VNS has the potential to improve the quality of life of those that have epilepsy. For example, an individual with a diagnosis of epilepsy lived in a 6-person group home. His dream was to eventually live in an apartment with minimal staffing. However, his seizures were complex, would happen multiple times per day, and injuries were frequent. In his case, medication management was difficult. He eventually got a VNS, and his quality of life drastically improved. As a result of improved management of his seizures, he was able to fulfill his dream of living in an apartment on his own. First aid for seizures. Let's do a review of the information thus far and learn about first aid for seizures in the following video presented by the Epilepsy Foundation.
Epilepsy is a chronic, long-standing condition, and it's characterized by recurrent seizures, so more than one seizure, and it is due to abnormal electrical activity or an electrical storm in the brain.
So there are a variety of different causes of epilepsy. Some of them are genetic predispositions, so people who are born with a tendency to develop epilepsy at a period in their life. These are usually syndromes that develop at a certain age. They have certain seizure types associated, may have certain characteristics on EEG. and often have a fairly certain prognosis of whether they will get better and disappear in time or whether they will continue throughout life. There are other causes, such as injuries to the brain that may develop, like a stroke or maybe a head injury from a motor vehicle accident, for example. There are other congenital causes or reasons you're born with to cause seizures.
So seizures come in a variety of shapes and sizes. Some seizures are very clinically obvious to recognize. So for example, if somebody stiffens and has shaking all over, a generalized tonic-clonic seizure, that's the type of seizure that does not get missed. However, many persons with epilepsy who present with their initial generalized tonic-clonic seizure may have a history of other subtle seizures that were not recognized. And it's important to know the signs of those subtle seizures. Subtle seizures can involve such things as staring, and oftentimes those are mistaken or misidentified as problems with attention or focus. We see children who have absence seizures who will stare, or patients who have focal seizures with impaired awareness who can also stare. Those types of seizures can be more challenging to recognize. And then other seizure types, such as myoclonic jerks, can be mistaken as people being excessively anxious or excessively nervous, or just having the shakes in the morning. And again, those are important to recognize as seizures, particularly if somebody is presenting with a first obvious seizure, because that means that they actually don't have just a first seizure, they in fact have epilepsy.
And when that seizure takes place, again, my arm will maybe just go up for a second or two. I still have my consciousness, but I'm almost staring off, almost like I'm daydreaming. And someone might say something to me, I won't respond because I'm really not hearing them.
I had my first seizure when I was 17 in my high school. I was in a classroom working on the school newspaper, and I got up and fell to the floor and had a tonic-clonic seizure. We thought it was a one-time thing. I went to the ER, we did some tests, but I was basically told we just have to see what happens next. And then I had my second seizure on a high school trip.
I will tend to go into a daze for about 10 to 30 seconds. I'm not able to hear anyone and I'm not able to talk, but usually I come out of it and it's back to normal.
I have full body convulsions, and when I have my seizures, I'm usually unaware that I'm having a seizure. One of my seizures that I remember very vividly, my first seizure, I tried to talk to let somebody know something was wrong, but I could not speak. But I remember falling over and hitting my head and blacking out.
Some people with epilepsy may have particular triggers that make their seizures occur. And it's important that people with epilepsy make others around them aware of those triggers so we can avoid them in the environment that they're in.
There are common seizure triggers that are present for many individuals with epilepsy, and probably the most common one of those is sleep deprivation. So making sure that you get adequate rest, adequate sleep is really important. For many individuals, stress can also be a seizure trigger. So if there's a lot of emotional stress, mental stress, sometimes a lot of physical stress can also bring on seizures.
My main triggers are stress and lack of sleep. To handle my triggers, I have to make sure that my stress level does not go too high.
So there's a number of steps that an individual can do to help someone who's having a seizure remain safe. One of the first things that you should do is stay with that person, look at your watch, and time when did that seizure start so you know how long it's lasted. The second thing you want to do is make sure that person is safe. So if there's anything dangerous around them, you want to move that away from them. The third thing you want to do is you want to roll them over on their side, and that's because some people can actually vomit during a seizure, and you don't want them to aspirate that down into their lungs when they're having a seizure.
These are the main steps for providing first aid for persons having a seizure. Let's look at each step. If you encounter a person having a seizure, stay with the person and start timing the seizure. Remain calm. It will help others stay calm. Always speak in a kind and reassuring tone. Encourage onlookers to move back and give the person room. Ask someone to stay nearby in case further help is needed. Check to see if the person has a medical ID. Look at your watch and time the seizure from the beginning to the end of the active seizure. Timing the seizure will help determine if emergency help is needed. key concern should be to try to keep the person safe. During a focal seizure, a person may be awake or confused. To keep them safe, move or guide them away from harm. If they are standing or walking, steer them clear of dangerous situations such as traffic, stairs, or train or subway platforms. If a person is falling or has lost consciousness, and you are able to reach them quickly, gently guide them to the floor or the ground. Put something soft and flat under their head. Move any dangerous objects out of the way. Make sure nothing is blocking their face and mouth, and that they are breathing normally. Turn the person onto their side if they are not awake and aware. If possible, have their mouth pointing towards the side to prevent saliva from blocking their airway. This helps the person breathe more easily. Try to make the person as comfortable as possible. Loosen any tight clothing around their neck. During some seizures, it may look like the person has stopped breathing when the chest muscles tighten. As this part of a seizure ends, the muscles will relax and breathing will resume normally. Rescue breathing is generally not needed.
One of the most important parts of caring for a person with seizure is to make sure that you don't put anything in their mouth. One of the biggest misconceptions about seizures is that a person having a seizure would swallow their tongue, and that's simply not true. You shouldn't put anything in the mouth of a person having a seizure until they're awake and they are able to swallow. The one instance where it might be okay to put something in the mouth is if they have a rescue medication that has been prescribed by their medical team to be given to in the mouth to stop their seizures. We don't want to restrain a person when they're having a seizure, so don't hold them down. If they are walking around, you don't need to hold on to them unless they're walking into a dangerous situation, in which case you want to redirect them away from that situation. What's most important here is that we're not trying to make the situation any worse. And sometimes when seizures are over, people can become somewhat aggressive or combative. And for these reasons, we don't want to restrain them or hold them.
It is important to stay with a person until they are awake and alert to keep them safe from injury. Most seizures will end on their own within a few minutes. If a person is having any breathing difficulties, call 911 immediately. Be respectful, sensitive, and supportive. Ask others to do the same. Seizures can be frightening for the person having one, as well as for others. People may feel embarrassed or confused about what happened. Keep this in mind as the person wakes up. Reassure the person that they are safe. Once they are alert and able to communicate, tell them what happened in very simple terms. Offer to stay with the person until they are ready to go back to normal activity, or offer to notify someone they want to come stay with them. In some cases, it can be necessary to call for emergency assistance. For example, call 911 if a seizure lasts longer than 5 minutes, or the person is experiencing repeated seizures. Call for help if a person does not return to their usual state after the seizure, or if they have any difficulty breathing. Seizures that occur in water can be more dangerous because a person may inhale some water. Even if a person has recovered after the seizure, emergency help should be called. If the person is injured, pregnant, or sick, or is having a first-time seizure, always call for assistance. And call 911 if the person asks for medical help.
I remember being at church one Sunday at a men's meeting, and I had a seizure, and we're all sitting in a circle, and one gentleman, he got really excited. He didn't know what to do. He jumped up and tried to grab me, and one of the other men who recognized epilepsy said, "No, let him go. We just got to make sure he doesn't hurt himself." So the gentleman over here, he was educated about epilepsy. When people are educated about epilepsy, they will do much better in working with the individual who has the condition.
When I had my first seizure, one of my school nurses did an excellent job helping me to calm down, as I was unaware of what had happened. So she calmed me down. She let me know they had called the EMTs and that they had also contacted my mom and that she was on her way. And helping an 11-year-old scared girl calm down after her first seizure was so important to me, because I was able to go to the emergency room unafraid, which was my first ever emergency room visit.
So I think if we summarize all of that information for how to keep somebody safe during a seizure, there's really 3 things. There's staying with them, There is safe, so keeping them safe, making sure there's nothing around them, and rolling them onto their side. And just by doing those 3 simple steps, you can really help a person with epilepsy and significantly lessen the risk of any problems as a result of that seizure occurring to them.
Epilepsy is an unpredictable disease, and seizures can occur at any time and any place. And that's why it's important for everyone to be aware of what seizures look like and how to deliver seizure first aid, because you could help save the life of a loved one or a stranger having a seizure near you. To learn more about seizure first aid, visit epilepsy.com.
Additional seizure first aid protocol information for the individuals we serve. In addition to the reasons discussed as to when to call 911, we have to remember that individuals we care for require specific care and responses based on their diagnosis and the community they live in. Therefore, additional protocols must be implemented. Additional circumstances in which it is necessary to call 911 also includes an individual who is diabetic as well. If an individual is diabetic and has a seizure, you must call 911. Also, you must know and follow the individual plan of care, known as the IPOS. In the IPOS, it will state when to call 911 in regards to the length of individual seizure. This will be very specific to the individual's seizure activity. You must call 911 if the seizure is longer than 5 minutes or longer than stated in the individual plan of care. For example, the plan of care may state, call if a seizure is over 7 minutes, or call if more than 3 seizures in one day. It will be based on the individual's normal seizure baseline and activity. Also, you will assess for orientation by asking open-ended questions. Are they alert and oriented ×3? Ask them their name, what day it is, and where they are. You may have to tweak those questions based on the cognitive ability to answer. However, the key is to determine if they are aware of the situation in the moment. Asking questions in which the individual can give you a yes or no answer is not a good indicator of orientation as the individual is coming out of their seizure. Last but not least, when the seizure is over, vital signs must be taken. As a direct support professional, you will take the individual's temperature, pulse, and respirations after the seizure is over and document accordingly. Ask the individual where they would be comfortable having it taken, whether it might be right where they are or sitting in a comfortable chair, whatever is comfortable for them. Also, you will monitor the individual closely after the seizure. Some individuals sleep afterward, which is just fine. However, you want to make sure that you are in a place where you have an eye on them and not in an area where they are not closely monitored like a bedroom. Seizures are unpredictable. Therefore, you want to be able to continue monitoring for anything unusual or continued seizures, which is referred to as status epilepticus, in which it is always a medical emergency. When to call 911 and review. Call 911 if the seizure lasts more than 5 minutes or longer than the treatment plan, the IPOS states. If the person seems to pass from one seizure into another without regaining consciousness, this is referred to as status epilepticus, a dangerous condition in which seizures follow one after another without recovery of consciousness between them. If the person's first known seizure, if the individual is diabetic, pregnant, in water, or sustain injuries that require medical attention. Documentation. As a follow-up to the seizure that took place as a direct support professional, is important to complete documentation of the seizure event thoroughly. you must document in the following places. You will fill out a seizure report. You will document in the individual's healthcare chronological, and you will document the event in the staff log so that others are aware. A disclaimer. Whereas this learning module is designed to give you a general overview of the topic, the specific treatment plan for the person you are supporting needs to come from an assigned medical professional to ensure a safe, person-centered, person-specific practice. And as always, a big thank you to all of you and everything you do in helping keep the individuals we serve safe and healthy. We want to also thank each and every one of you for your hard work, dedication, and always keeping the well-being of the individuals we serve a priority.